Now, I'm not going to say very much other than housekeeping, because we've got some really brilliant speakers who know far more about this territory than I do. The one thing I will say, though, is that I guess in my career, I've never jumped out of bed in excitement about data collection. What I have done, though, is jumped out of bed in excitement thinking about social justice and inclusion. So in relation to this, this feedback and the discussion that we have, I'll be really interested to see how we can shape meaningful data collection that you can practically operate day to day to really improve the lives of the people we're here to support in their own terms. I've also agreed, by the way, that I'm not going to introduce people's job descriptions because they're far too long, people's job titles, and I'll offend our speakers by getting them wrong. But the first person I'll hand over to is Steve, who will tell you what his role is and then launch into his presentation.
Hello, Phil. Thanks very much, Phil. Hello, everyone. Let me start to share my screen. Hi, my name's Steve Chamberlain, and I am chair of the AMHP, the National AMP Leads Network, have been now for amazingly 10 years. I worked in mental health for over 20 years in London local authorities. I'm now an independent social worker. I'm freelance, but I maintain my role currently as chair of the network. And I have 8 minutes just to run through some of the issues, because certainly when I was working as AMP lead, as I was for my local authority for about 12 years, I developed quite a significant data set. But nobody ever asked me for it. Well, occasionally my AD would ask me for something at a day's notice, but and often I would get it, but there was never any formal capture. So, and we in the network have been really wanting, I think the network AMP leads across the country are absolutely willing and keen on getting their data collected and reported on properly nationally. Going to quickly run through a few things, and I know the other speakers are going to expand on this, so I won't go to too much detail, but just thinking about what the Mental Health Act reviews recommend. It's a live issue. We're really pleased it's a live issue now in the review and now the white paper. 3 recommendations: mention data or some sort of activity recording. 143 around specifically talking about a data set of AMP activity, which we have been asking for a long time. But I mean, the fact that the local authorities run AMP services, are responsible for AMP services, whereas all the mental health data is collected through the NHS, is a significant complexity. The issue around availability of Section 12 doctors and AMPs, this is one of my bugbears really, around the fact that there's a duty to provide AMPs under Section 13 of the Mental Health Act. There's no duty to provide Section 12 doctors, and we have responded to the white paper consultation on that. And finally, a minimum waiting time, and I'll come back to the complexities as soon as you start talking about collecting data. Then defining the data is you immediately get into significant complexity, and waiting times is one of those very important issues we've got, and delays, but immediately you get into complexity. Now Mark Nicholas is going to come on and talk more about this, so I'm going to confine this. I suppose this is my moan slide really. NHS Digital collect the data at the moment. You will know that there's annual data, comes out in around November, December for the previous full year. Used to be through the KP90 system. Now for the last 4 years, I think it's the mental health service data set. But they're reporting every year that the data is incomplete. They don't get data from all the providers. Personally, I'm really struggling to understand how trusts and providers can't provide such important data, which is about Mental Health Act detentions, but it's still incomplete. As you know, it really only counts state detentions and compulsion in the community. They're counted by CCG area, not by local authority area. Don't look about how the local AMP services are impacted and how it works with that, and specifically with my experience of London, that we have so many people in central London certainly who are from out of area. The figures do not necessarily won't tally. And just one example about Section 136 data, which is collected and has been for ages, it's incredibly inconsistent. And this is actual data published from different parts of the government in 2018-19. The Home Office believes there was 33,000 136 detentions in that year, 31,000 in England, another couple of thousand in Wales, I believe. NHS Digital data for that year states there was 18,000. Now, as we know, all 136 requests have to come through to AMP services, and we don't know how many we think there are across services, but I think, you know, that is a pretty significant discontinuity of data there. What's missing? Just a quick run through some of the things. How many mental health act assessments have been taken place overall? And you will, I'm sure, know that Claire Barcham did a really interesting piece of work about 18 months ago, a couple of years ago, and just a snapshot about how many assessments take place, because of course NHS data only count the number which lead to detention or compulsion. So how many informal admissions? How many don't result in admission to hospital? And how many result in alternative interventions, which of course the government and we are all absolutely keen to maximise and reduce the amount of detention and reduce the restrictions on people if possible. I mean, I don't need to rehearse the issue about the overrepresentation of Black and minority ethnic service users, particularly Black, African and Caribbean men. But what's the demographic character of those not detained? We have no idea. Section 135 is only counted in relation to those people that are brought to hospital under the authority of 135. It doesn't count how many warrants are obtained and how many are executed. And the NHS data, AMHPs data for 2019-20 said there was less than 1,000 135s recorded. That's the number of people taken to a place of safety. We've done a very rough recent survey because there's currently the Ministry of Justice are consulting on increasing the cost of the application for all warrants and court applications. And we reckon there were over 9,000 across England in 2021. So it's a significant difference there. We don't know about out of area detentions. We don't know about delays to assessment or admission. And this, I suppose, is the delays is my next last point from my last slide, really. A word of caution. It's our view that capturing national AMP activity for these reasons I've mentioned before is vital. Most services across the country are already collecting very similar data. I think it's pushing an open door to actually move to this. Obviously, there would be additional burdens for collection, because I think a very significant number of AMP services are collecting them manually on Excel spreadsheets. And there is very limited, to my knowledge, automatic collection, which obviously is an increased problem. But as I've mentioned already, simple numbers quickly become complex when you're defining methods of collection. So, for example, what is the definition of a mental health act assessment? When does it become a formal assessment and be questioned? When somebody goes out and has a look-see, or does it only have to be when 2 doctors and an ambulance turn up? I'm not suggesting that, but I think that's a question that needs to be asked. What is a delay? Certainly, I'm quoting the CQC report of Safe Place to Be back in 2014, where they did a survey of places of safety, and the predominant responsibility for delays were, according to the people in charge of the place of safety, AMPs. Now, we not wanting to get too paranoid and defensive about this, but I think there's huge issues around the availability of beds, the availability of doctors, especially in the early hours of the morning. But people interpreted it as the availability of AMHPs. So I think and people will be aware of the complexity of looking at delayed transfers of care when that legislation came in about 10 years ago. So that is my quick run through the issues for data, and certainly I would think that I think it's very important that we move forward in terms of capturing this, because there is significant additional data that could help us understand what's going on in mental health and with the Mental Health Act. Thank you. I'm going to stop sharing my screen now.
Thank you, Steve. Some fantastic insights there around kind of huge potential to use data, but also some significant blind spots that we've got. Welcome, Kate. Thank you for having only had a few connection issues, and last time around it was me having those problems and frantically trying to get into these sessions, but thank you for making it. I think now you're going to provide us with a Care Quality Commission
Thank you.
perspective. And I've been saying to other colleagues, I'm not introducing their job titles, I don't want to get them wrong. So if you just want to give colleagues a bit of background in terms of what your role is in CQC, and then we're interested to hear from you.
Okay, that's great. Thank you very much. So I think Letitia's going to be sharing my slides. That's great, thank you. So my name's Kate Regan. I work for the Care Quality Commission. I've worked for them for a few years now. My current role is I'm a Mental Health Act Policy Officer, and I'm from an AMP and ASW background myself. So so this is a topic that I'm quite familiar with and have had some exposure to during my work at CQC. Next slide, please. Okay, so I thought it might be helpful just at the start, just to flag to people. Often I talk to people who get a little bit unclear about what CQC's function is, and so this slide is really just helpful for anybody who isn't overly familiar. CQC was formed in 2009 from 3 different organisations. The Mental Health Act Commission was the body that originally had this strong mental health act focus, and that's sort of become incorporated now into CQC's work. And we've got a few different functions under the Mental Health Act, which our sort of remit comes from Section 120 in the Mental Health Act, and our focus is on protecting the interests of people whose rights have been restricted. We know that through Mental Health Act monitoring, by physically going to wards and talking to patients and providers about actions. We are also a member of the National Preventive Mechanism, which tries to highlight sort of areas where it highlights where people could potentially be subject to ill treatment in detention. And we have the second opinion doctor service, which people will be familiar with, and do our annual report. Also within our inspection work, our inspectors will also look at how providers are discharging their responsibilities under the Mental Health Act and balance ratings, and inspectors will also be having ongoing engagement with providers about Mental Health Act issues. And thanks. Next slide, please. So just to highlight to people, just waiting for the next slide to come up. Thank you. So just to highlight, we have there has been some previous work we've done where we've sort of been looking more widely at the overall system around the Mental Health Act. And I put a couple of links on this slide. There are a couple of reports that are on our external CQC website, which they were from, we did a collaborative review in 2017 looking at the rise in detentions under the Mental Health Act, and as part of that we visited some NHS trusts and independent providers and engaged with 23 different authorities, and that work and the service users and other stakeholders, and that work led to a couple of reports that we did about rising rates in detention and also about the organisation of AMP services. Just a couple of things to flag from that. I think some of our observations when we were sort of literally physically going and talking to local authorities and looking at data was that often there wasn't often there wasn't consistency, because of the way that things were collected, and that what we found there, that information does give a really rich picture, and it's really important to try and capture some of that information. So yeah, we found quite a lot of variance in the degree to which different services were collecting and using that data, and how they felt it was used by their local partner agencies as well. We also, when we do with our inspections, we do inspections of cross services and health-based places safety, and as part of those we often link with local authority teams. AMP leads will share with us some of their concerns. We have AMP focus groups sometimes when we do those, and we've often found AMPs are really helpful in identifying some of the problems in the system. And we have at times done specific admission and assessment visits where we've talked to AMPs to understand some of the local issues. Next slide, please. Okay, so just to highlight, there are some external legislative and policy initiatives which do sort of also highlight this importance. I think a lot of us have been learning from COVID as well, just the importance of system working. So I'm just mentioning a couple here on the slide. I won't go into the detail because these slides will be available afterwards, but in the independent review of the Mental Health Act, the Mental Health Act white paper, and the white paper on health and social care, which also came out this year, there's very much a focus on trying to understand systems when we're trying to evaluate you know, how things are working together, how well they're serving people, and how they could you know, potentially improve. Also, CQC's draft strategy that was out for consultation this year highlights our commitment to look at and capture the picture of how systems are working, and we've also got an equalities focus, and mental health at work is central to our focus at the moment. Provider collaboration reviews is something that we've been doing towards the latter part of last year, where we started working together with health and social care providers to look at to help with learning from how they've worked together post-COVID as well. Next slide, please. Okay, so the final bit that I just wanted to flag is that obviously at the moment there's a lot of change going on. We've also got CQC's inspection approach is evolving. There's a consultation on about that. In our draft strategy, data has been an area that's been identified as an area that we want to focus on to support smarter regulation in general. The NHS England published in the autumn last year their Advancing Mental Health Equality Strategy, and one of the areas that, you know, is a keen focus there is about how people access services, and a lot of the information that AMHPs has is really helpful in understanding the overall picture and some of those inequalities. Also, if national AMP data was available, that would provide information to support understanding patients' experience and trying to identify some of the delays or difficulties in overall systems. And if there was some national data available, that would also support a broader focus beyond hospital. And one thing we're just keen to sort of emphasise, we wouldn't want to create an additional burden for organisations, and it is very much about information that would be operationally useful for them, you know, as part of looking at their local systems and how things are working together. And we're very happy to be to work collaboratively and be part of that conversation about what's helpful to collect and how that would work. So those are just some of the things that that I wanted to flag, and I think the main thing is it's just really we really appreciate and understand how much of the overall picture AMPs have, and the importance of just having that in the overall picture. Thanks very much.
Thank you, Kate. That slight delay was me clicking and unclicking all the wrong things. Thank you for that. And a really helpful presentation that kind of picked up some of the system level aspects of this. And there is a lot going on, isn't there? Just going to try and prompt colleagues to think about questions. Maybe one of the things you could think about as you're submitting questions is from your own perspectives as practitioners, as leaders, in terms of the roles that you're producing, you're delivering locally for people. What are the sorts of provocations, questions you want to put to the panel that will make your day-to-day job, which I'm sure is complicated enough as it is, a bit easier? So the panel are really looking forward to kind of engaging with those sorts of questions and how we can pull these organisations and systems together so that it does make more sense for people on the ground. With that segue, I'll just hand over to Mark now. I think you've unmuted in preparation just to take us through to the next presentation. Thank you.
Thanks, Phil, and good afternoon, colleagues. Thank you for joining us today. I'm just going to build on some of the things, hopefully, that Steve was saying a little earlier. Let's just share my screen. So hopefully you can all see that. So just to introduce myself, I'm Mark Nicholas. I'm the Chief Social Worker at NHS Digital. I'm also the Senior Clinical Lead, so that means I've got clinical responsibility for a number of different things that we're doing here at NHSD. So I'm the Social Care Lead. I've got clinical responsibility for something called Child Protection Information Sharing, which some of you may have heard about. And also for the NHS app, which I'm sure all of you are downloading desperately as we speak in preparation for Monday. So just a little bit about NHS Digital. I think many of you are familiar with us and the kind of data that we collect, but I just wanted to make the point that we are commissioned by the Department of Health and Social Care and also by NHSX to be able to do this stuff. So we've got very limited ability to be able to do these things spontaneously, the kinds of things that Steve was highlighting. However, what we can do is collaborate with yourselves in order to be able to do some of that stuff. So I wanted to start with something that I heard from a student social worker, third-year student social worker that I was lecturing her group at university a few years ago. And she said to me, "Oh, I don't do data." And I was very disappointed, as you might imagine, because, you know, having newly qualified social workers coming through who don't do data is really not where we should be. And so I wanted to start with why we should do data. And basically, we can't afford not to, for a number of different reasons. The better understanding of service user and patient care pathways, the ability to link data for research and evaluation purposes, better data quality and definition to be able to compare across and make the best use of scarce resources. And, you know, not least really, that if our work, and this I think is particular to what Steve was saying about the work of AMPs, if our work isn't reflected in the data, it's kind of invisible at a national level. And, you know, if it's invisible at a national level, then it's no wonder that we're scrapping for crumbs off the kind of funding table when it comes to a comprehensive spending review. It also means that the public understanding and perceptions of social care are not as accurate as they could be. You know, you talk to members of the public about the NHS, and they've got a fairly reasonable idea of what the NHS does, but a far less clear idea of what social care does. And I would suggest that some of that is down to data and a lack of data to be able to kind of back up our kind of business case for the value of social care. And of course, that then has a knock-on effect for the role of AMPs within that as well. So, you know, working as I do with data geeks in NHS Digital, what they always say to me is, you know, what you need to be really clear about, it's no good kind of banging away at saying, you know, we haven't got this data and we haven't got that data. What you need to be really clear about so that we can understand it in our data geekery is two questions. So one is, what question do you want the answer to? And the second is, where can we find the answer to that question? Where's the best place to look for it? And so I thought it would be useful to look at some of the data that we currently collect at a national level and make the point really that a lot of these data sets that we currently collect also contain mental health data. So, you know, we've got the adult social care outcomes framework, which most of you will be familiar with. Phil, you definitely will be, because I know you'll be signing off these data collections on an annual basis. We've got the National Minimum Data Set for Social Care, which is about workforce, a biennial annual carers survey, service user surveys on satisfaction and quality of life, which local authorities collect on our behalf. The sort of newish SALT collection, short and long-term support, planned and unplanned reviews. And this came out of the zero-based review in 2010, but it's kind of already out of date really in terms of what ADASS and others within local government will tell us. There's a collection of data on blind and partially sighted, finance, adult social care finance and deferred payments. There's an adult safeguarding collection. There's the deprivation of liberty safeguards collection, which many of you will be familiar with, as well as guardianship collection, which we did some consultation on this year because there was a proposal from the department that they should cease that collection. And then the mental health services data set that Steve was talking about, which is, again, useful to point out. This is a data collection which is mandatory for clinical settings, but only optional for others. And that's one of the key reasons, I think, why often that data set is incomplete and it's not of as much use as it should be to those of us in social care. Key point about all that is it's annual aggregated data. And that is useful for performance purposes. When DASSs want to compare performance of one local authority with another, or when the minister wants to get an idea of what the performance is of a local authority, it's not very useful when it comes to meeting the needs of service users and patients. So where are we going? And it's an exciting time at the moment for data geeks. And even for me, who I'm not a data geek, but it is a very exciting time at the moment because we've been working very closely with the department and with ADASS on a joint project around client level data. So we ran some pilots over the course of last year or two, actually, in the Northwest. And there's a new direction which is forthcoming from the department to us, which says that we have to collect some data. So I did say that we were a commissioned organisation and we can only collect data when the department or NHSX tells us to. So that's great that we've got to that position. Participation from local authorities will be voluntary in that, but the data that the volunteer local authorities will submit is the same. So we will have a common data set. And I think as more and more local authorities come on board with this voluntary data set, it will start to produce some really useful information. I often say within the NHS, if you look at the amount of data that we collect from the NHS, you can't roll over in a hospital bed without that data being transmitted to NHS Digital. And having that clunky annual aggregated data sets for social care is just, it's just miles away from when we need to be. So having this kind of client level data is really, really important. I've put some examples of the kinds of information that we'll be collecting there, and what we're likely to be directed to do by the department is to link that data with other data sets. So the data sets on hospital admission statistics that we collect from health, which will enable a really kind of thorough analysis to be able to take place. And important as well to recognize that this is live data, so it's bang up to date, it's not annual, and that data will be flowing from the local authority to NHS Digital. We've got a precedent for this already in CPIS, Child Protection Information Sharing, that I mentioned earlier on, where overnight that data is uploaded to us, and is then immediately available to any non-urgent care setting across the country. So we've got a precedent to be able to build on with this data set, and that data will be landed on our new data services platform, which is definitely data geekery, and I'm not going to explain any further. So we work together with the department, with the AMP network on the recommendation in the mental health white paper that Steve covered earlier on, which will cover, or we hope will cover, a number of mental health act assessments, the details of those assessments and the outcomes. And from all of this on this slide, what we hope to be able to do is some predictive analytics. So who are the people who are going to need the services in the future, and what can we do now that might prevent those situations arising? Now, that doesn't replace the expertise of workers on the front line who generally know a lot of this stuff anyway, but it does provide a business case for financial investment in those preventative services, we would argue. I'm just going to say a little bit about this. So there's a lot of technology that we're currently using in mental health. These slides will be available, and there's some links in there to some of the technology products that I'm talking about on there. We've done a lot of piloting with local authorities around this kind of stuff. So working with the LGA, with local authorities, and from an NHS Digital point of view, to pilot a lot of this technology already. So if you Google Social Care Digital Innovation Programme, it will take you to the LGA website, and you can browse to your heart's content on lots of different initiatives that we've seed funded with a number of different local authorities that cover all of these areas. So I want to come to the question on this slide, or the questions. And this is something for us to think about, and I would really value views in the Q&A on this. How well are we, as social workers and AMPs, equipped to be able to understand some of this stuff that we've covered today, and to communicate with service users and patients on this stuff? So do we know it well enough to be able to explain it? And also, not least, have we thought through the ethics of some of this stuff? I've talked about predictive analytics, which is controversial, because what we don't want to be doing is stereotyping people. If you've been abused as a child, then you're going to become an abuser. That kind of incorrect and insulting way of using data. We need to think through, and we need to be in charge of, as professionals, the ethics around this kind of stuff. So we have to get involved in it, is what I would argue. We did some initial work on this, which was published in March last year. Really bad time to publish anything at the beginning of COVID, on digital capabilities for social workers, which kind of outlines some standards that we would suggest that social workers need to be able to comply with professionally. That research was done by Sky and BASWA, and we have been in conversation with Social Work England about how we can incorporate some of that stuff in both qualification requirements for social workers and also for ongoing CPD. And I also wanted to mention, lastly, something called Joining Up Care, which is an initiative coming out of the department at the moment, which we think will be well funded for initiatives coming to social care. And one strand, there's 3 strands in Joining Up Care. One strand of that will be around support at home. So basically trying to keep people out of hospital, out of residential care, and supported at home. And one of the key ways of being able to do that is through really good up-to-the-minute data and really useful technology that meets the needs of patients and service users. So I think that's me done. Thank you very much. Really look forward to the questions later on.
Thank you, Mark. That's fantastic. I thought there's a few good kind of provocations in there, which I think is great. But I think that whole "what's the question we're trying to answer" angle is, for me, is absolutely key. I think it was helpful, actually, that my sort of role, I'll get these reports every now and again, but what use is that to the people on this call? What use is that to you in terms of the insights that you need day to day to follow through your commitment to support people better? So getting us into that practical ethical space, I think, is really important. I think that's a great segue now for me to introduce Nhs, just to take us through into our final presentation. Thank you for the questions starting to trickle in. A good question for CQC's coming already, and we'll keep track of those. But yeah, do listen to Nhs, but also have a think about a few questions you might want to put to the panel for later on. Thank you, Nhs.
Oh, hi. Thanks for the invite. It's a very special event. My name is Nhs Lilo. I am the chair of the National BME Forum. I really would like to start by wishing happy Eid to Muslim delegates. The Muslim community started yesterday and today celebrating after a month of Ramadan fasting. So it's a very special time to celebrate, and those Muslim delegates who joined us, doing a fantastic job to be here with us. So a lot of celebration and happiness all round. So thank you. This is a big topic today, data collection, and I will be very brief. There have been development over the past 10 to 15 years with a huge impact on race relations and race equality. Mental health social work is urgently required to acknowledge and respond to. I must honestly say, mental health social work is well placed, but has to develop further to meet the landscape. Black Lives Matter brought to the surface explicitly the cancer in society, racism, and its manifestation denying Black people basic human rights, evidenced by the continued institutional racism within the NHS and social care. We know that Black people and other ethnic groups are more likely to receive service and outcomes from mental health services, with often very punitive measures when care and treatment provided, such as 4 times more likely to be sectioned under the Mental Health Act. Black people are also 10 times more likely to receive community treatment orders discharged from hospital after the section under the Mental Health Act. Therefore, racial disparity in the use of the Mental Health Act is an ongoing injustice. This government acknowledged this back in 2017 and initiated independent review of the Mental Health Act. And a year later, back in 2018, the review published its findings and recommendations. The recommendations are underpinned by a commitment to modernize, review practices, and where appropriate, redesign roles, such as that of an AMP and mental health social work, with the purpose, of course, to reduce detention rates and addressing racial disparity and discrimination. Therefore, collecting data is the cornerstone of monitoring and reviewing current situation and subsequent development of plans and service redesign. The government accepted most of the recommendation from the review and the Mental Health Act white paper, published, of course, in January of this year, earlier this year. I will now focus and bring to your attention to some of the main direct measures and proposals to combat racial discrimination within the white paper. It states, we are committed to taking action on the issues which the review shone a spotlight on and addressing the underlying causes of these disparities. First, the paper states, we aim to improve the transparency of decision-making. Secondly, provide greater choice and autonomy. Thirdly, increase the ability for patients to challenge decisions. The white paper explicitly states then, these changes will benefit all people subject to or at risk of detention, but are designed to have a particular positive impact for people from BAME backgrounds. So, a question, how are we going to translate this into practice? And then the challenge is to ensure its sustainability. It is as clear as the nose on my face that we need to collect data robustly in order for us to design and plan service delivery. First, to support transparency of mental health activities and decision making. Secondly, to provide greater choice and autonomy for those being referred and assessed under the Mental Health Act. Third, to increase their ability to challenge decisions under the Mental Health Act via, for example, hearings and tribunals. For example, we need to collect data on care, treatment, length of stay, and whether they were suitably interviewed when assessed under the Mental Health Act. Let me give you a live example of a local authority. It monitored the use of the Mental Health Act on non-white British service users from January 20 to January 21. One of the key findings was that the use of interpreters very low when assessing non-white British service users. Therefore, we need to critically examine whether we are assessing people under the Mental Health Act in a suitable manner. That is under Section 13 of the Mental Health Act. This is legally binding. And if this is not satisfied, then the detention is likely to be unlawful. Of course, this may also impact on other duties, that is consulting and informing the nearest relative as part of the Mental Health Act assessment process. So you can see how imperative data collection and analysis in order to promote and champion the needs and rights of Black and ethnic minority service users, carers, families, including communities. Secondly, the white paper refers to and highlights the importance of culturally appropriate advocacy. So, in addition to existing advocacy services, so in addition to existing advocacy services, arguably AMHPs and mental health social workers have a significant role to play here in advocating for mental health service users, the carers, families. But to make real difference, we need to consider and address current barriers and challenges. The third main proposal and or recommendation from the white paper is to ensure a diverse and representative workforce at all levels. Is it critical to making a progress to address disparities and racial discrimination? The review found that parts of the mental health workforce do not reflect the population they serve, meaning there are gaps in the delivery of meaningful support. Finally, service users highly value social work for its focus on the whole person, drawing upon social perspective of mental health beyond clinical symptoms. So capturing data that consider alternatives to detention, strengths, capacity building, shaping of services by involving service users, which include the person and his or her wider network. So in conclusion, to improve outcomes for BME service users and address disparities, social work urgently needs to develop to meet the new challenges and changing landscape of mental health. And of course, robust data collection and monitoring is the cornerstone in working towards that. Thank you very much. I am on holiday, visiting my family for the first time after a year. So I'm working from my phone. So but I'm so glad to be with you and given the opportunity to speak to you. Thank you very much, and back to you, the chair. Thank you.
I don't know how many of the rest of the 96 of us on this call are on holiday, but hats off to all of you who are on a holiday on Friday who are participating in this kind of really worthwhile section. So just want to thank all four speakers for some really interesting, provocative, erudite kind of contributions. I'm now at the stage of thinking, be careful what you wish for, Phil, when you ask people to put questions forward, because we've got some really good questions that have been suggested. I'm just going to try and dip in and out of a few of those. And Kate, where I might start, if it's okay, is a question that a colleague has raised about the kind of Care Quality Commission, kind of quite helpful commitment to kind of system reviews or system perspectives, collaborative perspectives, rather than too much focus on kind of single agency chasing data. I think the question was just interested in a bit more development from you about how we might get to that point, which just for a worthwhile endeavour.
Yeah, thanks very much. I think in relation to our work under the Health and Social Care Act, so the more traditional inspection side of things, it's probably a bit too early to say exactly how that might look, because there's sort of been a public consultation, and it's all very much in development at the moment. In relation to our sort of mental health act monitoring, there in the white paper itself, actually there are a few paragraphs on this which people might want to have a look at, because it's quite helpful in there. The government sort of set on its thoughts on this. But essentially, I think they're looking at trying to review how our role might be extended, but they're sort of recognising that would involve, engaging with various stakeholders, local authorities, CQC, to think about how that might look. I think that I mean, what we know, I mean, it does make it clear as well, you know, that it would be really about looking at how effective joint working arrangements are working, trying to identify issues along the detained patient pathway. And, you know, it does say in the white paper, CQC wouldn't be responsible for regulating or taking enforcement against CCGs or local authorities. But it's more trying working cooperatively with system partners. And if anybody's ever experienced one of our admission and assessment visits or the appreciative inquiry we've done before, it's been very much sort of working alongside the authorities as partners.
Now, we might have a few audio issues with Kate now. Just checking with other panelists.
Sort of hearing them, how things are working, that sort of, when I've touched on that.
Your audio, I think, is gone. Other panelists experiencing that too, yeah. So apologies, Kate. I think I might just move on to a further question, if that's okay. Had a really helpful question. Colleague Jane submitted. I'm just going to paraphrase it slightly, and I'll work out as I'm asking this who I'm going to ask for it first. But I might ask Steve actually. How do we make sure that data about AMP activity captures the work that AMPs do beyond detaining people in hospital? So I think underpinning that question from Jay is just that sense that AMPs get typecast against mental health act assessments and actually a much wider and broader set of really helpful interventions that make a massive difference to the human rights of the people they're supporting. So what's your sense of how we can get that kind of focus as well, Steve? And obviously I'm not going to stop any other colleagues from having a go about that one, but maybe start with you, Steve.
Thanks, Phil. Yes, I mean, I quickly responded to Jane's comment because I think it's crucial, really. I suppose to a certain extent, the network ourselves, we've been asking about national data collection for a long time, but we've toned down our ambitions, basically, because we've been told numerous times about, you know, additional burdens, monies, and we should only collect what's absolutely necessary. So I think it is really important to actually to know what sort of work is going on to prevent admission, especially in the context of the current white paper, where the government is so keen on reducing the use of the Mental Health Act. So, you know, I think it's crucial. Going back to what I said during my presentation, I think defining when a Mental Health Act assessment starts will be an interesting point itself. Does it only start when you arrive at the person's home with 2 doctors present? I don't think that should be the case. But on the other hand, you know, does it start when you go out because you're concerned about somebody's mental deterioration? So, you know, that you immediately get into complexity around defining that. But it is incredibly important data to know what work is going on to prevent admission, and it feeds directly into the government's own agenda.
Any colleagues want to add anything to that answer? It's pretty comprehensive, I think, from Steve. Anything anyone wants to add? Otherwise, I shall shift on. I think there's been some questions. It's been an interesting discussion because on the one hand, Mark's quite rightly told us that data is everyone's business. And I think that's absolutely right. But on the other hand, Steve said earlier that simple numbers quickly become complex. And we kind of become kind of rabbits in the headlights, don't we? And I especially feel like for AMPs and colleagues, it just feels like some of it must feel kind of nightmarish in terms of trying to wade through where your own individual agency is around, your own autonomy is around working with data and using it to make the world better. So just a question, I'll probably go to Mark on this one. Do you think the data currently collected to support people with mental ill health is accurate? is it supportive to AMPs, and is it properly shared across involved organisations? And how can we improve those kind, if there's any shortcomings there, how can we improve those?
Can I just come in after Mark as well, please?
You push you can, Steve.
So the answer to the first part of your question is no. It's not. It's not accurate. It's not supportive. It's not properly shared. And you know, there are multiple reasons for that would you know, take up more time than we've got available, I think. I think what we could do to improve it, and this is a bit of a hobby horse for me, is as social workers and as AMPs, we have to take control of the agenda. And, you know, that's difficult because, you know, because of the what I talked about in my presentation about, you know, how well equipped are we to be able to operate in this area. You know, it's really interesting working as a, you know, an ex-local government employee in the NHS. You know, clinicians have such a clout within the NHS in terms of informatics, as we would call it. You know, things don't happen unless the clinicians involved say they should happen. And, you know, when things are not right, the clinician says they're not right, then they get put right eventually. You know, it's not entirely command and control. And I think, you know, there's some good examples in the country of where principal social workers in particular, you know, they're very involved in, for example, which case record system we use to record this on, how that's deployed, who's trained in it, making tweaks to the case record system to get us the information that we actually want rather than what the supplier thinks that we want. You know, so I think it's very much about engaging with this agenda. And, you know, and I'm talking we as social workers and AMPs, I'm not talking about we NHS Digital, we can collaborate together to make that better. And an example of that is the data set that we've worked on with ADASS for this client level data collection that I mentioned earlier on. You know, this is the stuff that we really need to know in order to be able to run this activity. This is what DASSs need to know in order to be able to run their services. This is the stuff that social workers and AMPs need to know in order to be able to have an idea of the efficacy of what they're doing on a day-to-day basis. So for me, it's very much about engaging with the agenda. You know, that's the start of it. And then there are multiple things after that we could do, which I won't spend too much time talking about.
Thank you, Mark. So I'll just bring Steve in.
Hi, just a quick one about a question and an answer, then a response to a question that's come already, which links to this. It's about the fact that I said that most local authorities, a very large number, already collect similar data. The reason it's similar and not the same is because there's never been a requirement. There's never been a demand to collect that data. It is absolutely impossible to actually make people collect identical data across 152, I think, this year now, local authorities. But what my point is that, in my opinion, the similarity of the data means it would not be complex to actually go to a stage of, you know, a lot of data is already being collected and it is, you know, pretty compatible. But, you know, similar, absolutely agree it's the problem. That's why you need a national system.
Can I just chip in on that, Phil, before we move on? And that's why the client level data set that we're collecting is voluntary, because we don't want to get into those conversations about burden and the costs and all the rest of it. Otherwise, the whole thing will sink without trace. But, you know, if local authorities are going to participate in it, they have to collect the same data. That's the deal.
Thank you, Mark. And I think I just might ask you a kind of a follow-up question that just links to this discussion. So we've got, you know, I can't see who's on the call. I can see that 4 people have left for their lunch, by the way. I can't see exactly who's on the call. I'm keeping an eye on your numbers. I know when you're leaving. But in terms of this point about collaboration, with collaboration with AMPs and social care mental health professionals. So I think people will be hearing a lot of commitment from people on this call to make that collaboration happen. How do we do it there? How do we make it feel real for AMPs on the ground that data is actually helping them do their job and address the social injustices you described earlier?
Yes, I mean, I remain practicing AMP, and I'm glad to say that, because I see and experience practices. For example, the nearest relative involvement, engagement, consultation, informing is a key and part of the mental health act process. I often come across in my practice that the nearest relative is not recorded, and sadly, I often come across service users, for example, sectioned under Section 2 of the Mental Health Act, already been in hospital for 3 to 4 weeks and no contact with their nearest relative. So you're talking about collaboration. I think there is need to be closer collaboration between the NHS and local authorities to work together in this area. Involving families, carers is a key when appropriate and when necessary. So that's an example. Again, language. Agency could collaborate for resources. And I used an example during my presentation of a local authority that was monitored the use of interpreters. And it was a useful exercise. They found very, very low use of interpreters. And they questioned themselves, is it because of inconvenience? Is it inconvenience? And they were honest, that local authority was honest to examine that, because it's a key. If we don't use an interpreter when necessary, that means the whole legality of the assessment is questioned, because we need, as a requirement, as a legal duty, to interview a patient service user in a suitable manner. So are we doing that? So it's a really, really useful exercise. So yeah, it has to be a whole system approach. It's more effective in use of resources. We need to be prepared, plan properly, rather than just being reactive. And things, I mean, I am optimistic. I am a fan of the Mental Health Act white paper. There are recommendations that we will see a statutory care plan. We will see an advanced decision document. So there will be the services will be at the center. Carers, families, the wishes, feelings, will be at the center. So I am optimistic. Things will be changing, but that will require work, local authorities, in collaboration with partners to make that happen. Hope that answers the question.
It does. Thank you, man. And I think as well, there's some useful statements that colleagues are putting in the questions as well. So, for example, this kind of challenge really that echoes what Mark said about local authorities upping their game about the way they support data collection and support their mental health.
Yes.
So, an example given around doing it for dolls, perhaps, but not doing it in the same way for mental health. So, there's a good challenge for me to take back into kind of ADASS colleagues. What I want to do actually, because this is Mental Health Week, I want to support the mental health of people on this call and give you a bit of time back actually. So I want us to finish before 12:30. So you've got a little bit of time just to collect yourselves. But I just want to pick up a couple of questions more. One a bit of a sharper end and one kind of a bit more preventative. So I'll start at the preventative end and I'll just see which panelists want to answer this. Helpful question from Kathy around not entirely focusing all the time on sharp end mental health admission issues. What are the panelists' insights around data around, for example, well-being, social contact, isolation, the more preventative end? That if there's a system we can work more effectively on, we can maybe reduce some of the data that we're needing to collect at the sharper end. Just want to get some insights around prevention from the panel there. Whoever wants to go first, unless I have to pick on someone.
Shall I chip in on that first, Phil? So, yeah. So I haven't always worked in adult social care. I worked in children's social care as well for a while, and I had the privilege at one point of being director for a number of Show Start programs, and of course, Show Start, for those of you who remember it, kind of sank really during the first period of austerity, because we couldn't prove well enough that preventative services worked. And that's always the challenge, isn't it? So how do you prove that you prevented something? And the only way of being able to do that, I think, is through operating in a data-rich environment where you can show that if you do this, in the majority of circumstances, this will happen. And so the ability to be able to collect detailed data from local authorities, which contains mental health activity, and then to be able to link it with health data showing improved health outcomes is the answer to the question, I think. But that kind of stuff is complicated. It needs research funding, and it needs the data to be there and linked in the first place. So it's not an easy answer, but I would suggest that ultimately that's the answer to the question.
Thank you, Mark. And obviously, anyone else wants to come in on that?
Can I just say, I suppose, really thinking back, I'm not up to speed with the current NHS collection of stuff other than detentions, really. But one of the problems is, I think, that mental health activity has traditionally already been collected by the NHS. I mean, the one that helped well-being score, incredibly crude. The Honos score, very incredibly crude. But it's all collected in the NHS. There appears to be very little systems for collection within local authorities. Leaving aside the stuff that Mark's already talked about is actually about how you define it and how you collect it. But I suppose it's been reflected in the last 10 years. I mean, to go a bit tangential here, but local authorities, so many local authorities have ended their partnerships. They are now set apart. I've got a different system in mental health than the NHS. So it's more difficult to work together in terms of data when systems have been problematic for many years, even before this disaggregation process. But the disaggregation, I think, has just made it significantly more difficult. But it's a historical thing. I don't have an easy answer how you can move away from predominantly clinical NHS measurement of these sort of things where it's happening to actually improve local authority measurement and collection.
I think there's something in the way that Mark described that kind of Sure Start challenge that's kind of a back to the future kind of attempt to get into that. And actually, Steve, we're obviously still well old as a panel now because you've almost prompted the final question, which Seren's put in forward. So Seren's talking about the reference to the idea of defining a delay for mental health assessments and how the panel would propose to negotiate the tension between speed of response and what might be better for any given person. And for me, I think that's really helpful. Delays is always a kind of a massive issue, but that attention, as you say, Steve, and often what we see is NHS data and maybe some lived experience. So we might want to get some insights from the panel around quality of life as well, and around outcome and around quality of experience and how that interfaces with the chasing the numbers around delays that we're often asked to do. So who would like to come in on that provocative note? Can
I come in? Thanks. Yes, I mean, I agree, seem to be black and white. From, as I said earlier, I remain a practicing AMP. I was on duty earlier this week. Actually, some delays can be positive but it depends how we define delays. I think there is a challenge. The role of the AMP remains misunderstood by other agencies. An AMP, to ensure he or she carried their duties effectively and legally and lawfully, they need time to gather information. They need time to liaise with other agencies and to inform the decision-making process. We know certain delays, no beds, and availability of Section 12 or other doctors, and an availability of colleagues from the police, ambulance. It is a complex activity. So I think it's about how do we, quantify and qualify all of that. It's very difficult and it's very challenging. And I feel it's often unfair, and I must say that, unfair to local authorities. I think, in my opinion, and I've worked in a number of local authorities do a fantastic job of resourcing the AMP service. They do at their best, in my opinion. But we are living in that reality. It's need to be understood. The AMP role is complex, and what the local authority have to deal with is complex. And the best way is about working together, understanding our respective roles and respecting our roles. Because really the main objective is to do the best to our service users. And they're arguably often in the most critical, maybe the saddest moment of their lives, and that of the lives of their loved ones. So it's really complex. I'm speaking from the heart. So it is crude, and I agree. But I think local authorities do a fantastic job on the back of real challenges. So
can I just come in quickly?
Yeah, yes, Steve.
Yeah, sorry, did you finish? Had you finished, Imad?
Yes, I have. Yes, I have. Thank you. I have. Thank you.
Right. Yeah, I mean, I answered the question online. I mean, the recommendation 153 of the review, mental health review, worries me. It says the government should consider introducing a minimum waiting time standard for the commencement of the Mental Health Act assessment. And I just echo what Imad said. There could be good clinical reasons for a delay. I've used the word delay carefully, for an assessment not proceeding within 3-4 hours or whatever. I'm not talking about Section 136 here. I'm talking about general assessments. And I think that it's much more subtle than that. We need to be thinking much more carefully. Just going back to the quote from the CQC, A Safer Place to Be publication, and the first Crisis Care Concordat document, I think the fact that AMHPs have statutory duty to oversee an assessment, when the assessment doesn't go ahead as quickly as people want it to, they immediately, the evidence from those documents is that it is the AMP's fault. Now, it may be a problem with the AMHP service, but I think that it did overestimate that because people immediately think about that because they're responsible for coordinating. And so I think that's it's really important. And as my last point is, going back 10 years when the government introduced legislation around delayed transfers of care from acute services, I think there was money attached to that. And where there's a will, there's a way. I mean, there were systems were developed in order to sort out these disagreements. There were multi-agency meetings in acute general hospitals about reasons for delays for detox in general care. It never got extended to mental health. I know there was discussion around that. So I think it's possible to do, but you need to we must clarify, it's not a simple matter. We need to think about the complexity, the subtleties of that.
Thank you, Steve.
So I just want to give you, I'm going to follow through on my promise. I'm going to give you 10 minutes back of your lives today, colleagues, because I know how absolutely stretched you are day in, day out with the day job, and it's not getting any easier. I just wanted to thank our participants today. So thank you to Steve, Kate, Mark, and Emad. I also want to thank Letizia and Claire, who've done some great work behind the scenes to actually bring this session together. So thank you, colleagues, for that. And again, to thank Home Group for providing the sponsorship. Just one of the final closing points to me. I think you probably got a really clear commitment from each of the panelists who see data as important, but don't want us to get into a cost of everything, value of nothing approach to data. And you've seen actually and really helpful challenges and prompts from yourselves as well as delegates. So thank you for that. Things that local authorities need to do better to value the AMP's role in the broader sense of mental health, and also to collect the right data. Things that the NHS needs to do, needing to support the CQC with this whole system perspective that counts things in a proportion that one really adds value. But I think above all, ways to try and involve you in the work so that it makes sense from your perspectives, rather than it being data for data's own sake. So it's going to be a really interesting area of development. And just thank you again for your time this afternoon. I hope you get a restful weekend and not too many people on rotas or things that take you away from relaxation. Thank you.